الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. It's a great pleasure for me to announce the start of knee arthroscopy course in the Bahaa Orthopedic Online Review course. Today is the start. We will start with our beloved professor, Professor Dr. Bahaa Kornah, Professor of Orthopedic Surgery at Al-Azhar University, speaking to us about examination of the knee, and will be followed with our beloved professor, Professor Dr. Khalid Matrawi, Professor of Radiology, Alexandria University, and he will speak about MRI of the injured knee. Our moderator today will be Professor Dr. Hussam Al-Bigawi, Professor of Orthopedic Surgery and Knee Arthroscopy, and the chairman of the Knee Arthroscopy Unit in Bahaa University. Dr. Hussam, may you start? نبدأ دكتور حسام.
بسم الله الرحمن الرحيم. يسعدنا ويشرفنا ان احنا نبدا كورس ني ارثروسكوبي في بنها اونلاين كورس، ويسعدنا ويشرفنا وجود اساتذه من جامعات مصر المختلفه، وهنبدا ان شاء الله بالاستاذ الدكتور بهاء كورنة، استاذ جراحه العظام في طب الازهر. The title of the lecture is in the examination of welcome Dr. Bahaa Kornah. Would like to introduce Dr. Bahaa Kornah to start.
Thank you, Dr. Hussam, and it is my great pleasure to be in this course, and always Bahaa pioneer in introducing and helping the people for more teaching and learning. Thank you, Dr. Muhammad Ashab, for this thinking and expanding this knowledge. My talk today, it is about examination of the knee, and just, I think, welcome for everybody who is listening to us. And this is our flag, Egyptian flag, and this is my pictures. And it's just always I ask this: who has a driving license, and who can drive? Always I put this because you always driving in the road and you found a lot of signal, and sometimes you don't know what is this signal, and that is why in examination you have a lot of signal. But if you don't looking for it, you will missing it. This is a signal mentioned for you that it is tahziriyan, that there is something, the road is coming to be closed and will be opened for other side. Okay, our objective from this talk is to learn how to do a quick and thoroughly knee examination and be able to examine the collateral ligament, cruciate, menisci, patellofemoral syndrome, osteoarthritis, Osgood-Schlatter, patellofemoral, patellar tendinopathies, and bis anthracis and iliotibial band. This is some diseases around the knee, and you have, when you examine, you have to looking for this as a differential diagnosis, including iliotibial band, articular cartilage, symptom, osteoarthritic plica, and all these things. So the task at the hand, how to examine the patient, it is you have to go for systemic approach. Systemic approach means that you have to go the step ladder. You have to look for the history from the injury or non-injured, and then listen and touch and think, and then obtaining an imaging study, and then interpret this, and then go for final diagnosis, correct diagnosis, and then the best treatment. If you're missing one of these systemic approach, you will fail and you will not giving a good diagnosis and good management. So for the knee, the main complaint of the knee can be categorized into 4 categories, like pain, swelling, instability, and deformity. And each one has many subgroups. So from the history taken, it is asked about injured or non-injured, when and how, what is the symptom, and the level of the activity after and before the injury. So the mechanism of injury is very important. The position of the knee in respect to the body as a whole, as the time of injury, it is a very important point, and you have to ask. This means that the limb, if it is fixed and the body rotates, there is a rotational injuries. So how to diagnose the knee complaint? Look for the history. You can classify this patient according to the patient age and the sex, and does the knee swelling after the trauma or not? is there is a mechanical problem after that or not. So this is a historical clue. You can just put it in your mind. If it is non-contact injury with a pop, this means maybe this is an ACL injury. If the contact injury with a pop, medial collateral ligament or lateral collateral tear or meniscus or tear or fracture. Acute swelling after a trauma, this means ACL tear or PCL and other injuries. Lateral blow to the knee means that there is a strain on the medial collateral ligament. Medial blow to the knee, this is lateral collateral ligament. Knee giving out or buckle means it's ACL tear or patellar dislocation. Falling onto a flexed knee, this is a PCL tear. If we classify this put it in your mind according to the age and sex, this is the most common. From the age from 0 to 12, this is the discoid lateral meniscus, both in male and female. If it is from 12 to 18, it is osteochondritis dissecans or Osgood-Schlatter in the male, but in the female, it is the first patellar dislocation. If it is from 18 to 30, longitudinal meniscal tear from the trauma or recurrent dislocation of the patella in the female. From 30 to 50, rheumatoid arthritis and rheumatoid arthritis both. And from 40 to 50, degenerative menisci, both male and female. 45 and above, it means also arthritic changes. Ask for the swelling. This is another complaint. The effusion means that there is a swelling. The presence of pathology must be investigated. And this, when you aspirate it, you have three things, either fluid or blood or pus. Absence of effusion does not exclude pathological, but less likely. Long-standing meniscal lesion and also arthritic. What about the mechanical problem? The history of initial injury, the mechanism of injury, you have to ask about the degree of the injury, direction, and incapacitating after the injury. And you have to ask about the giving way, going down stairs or jumping. This means this patient maybe has an cruciate ligament. Twisting or walking uneven ground, this means meniscal injury. Knee locked, either through or pseudo locking. Never locked in full extension, this is pseudo locking. Full flexion but limited extension, foreign body or meniscal click. And pain, and you have to ask it about the character of the pain. So also have the duration of the pain. Is it less than 6 months or more than 6 weeks or more than 52, more 1 year? This means the chronic degenerative. And where is the pain, the side? Is it anterior? Is it posterior? Is it medial? It is lateral. And always consider a referred pain from the spine and the hip. Never examine one joint without examining the proximal and the distal joints. So the history is very important. Ask about, is it traumatic or non-traumatic? Traumatic, maybe subgrouped into fracture, dislocation, muscle tendon, meniscal injury, ligament. Atraumatic, consider infection, the systemic disease, gouty tumors, inflammatory arthritis, referred from lumbar spine and the hip and also arthritis. This is a mechanism of injury. If you have to put it in your mind, prolonged flexion and hyperextension, like the people who is working on the ground, the posterior horn of the medial meniscus and the lateral meniscus or ACL, hyperextension injury, anterior tibial or femoral condyle or BCL or ACL, valgus with flexion, rotation, lateral tibial and femoral condyle. Varus injury, medial tibial and or femoral condyle, lateral collateral ligament. Flexion with posterior tibial translation. This is a dashboard like in car accident, like a BCL, posterior dislocation of the knee. What is the aggravating factor? Is a meniscal pathology of long standing. It can giving way and locking and resistant swelling and thickening of the synovial membrane with a pain specific in the joint line. Patellofemoral joint pain, which is pain on kneeling and squatting, pain on stair, and pain on sitting, and you hear about the crepitus. What other aggravating factor in osteoarthritis? The way, during weight bearing and change the position, start staring, kneeling, stiffness, and also ligament pathology like moving valgus or varus or may giving way. Other important questions you have to ask during the history. Did the knee swelling and was it immediately? Immediate swelling indicated hemarthrosis, and this is sensitive for intra-articular structure like ACL. And there is associated pop or click. Does the knee giving way? It is a pseudo giving away or true giving way. Does the knee locked? Again, pseudo locking or true locking. Morning stiffness is very important to excluding osteoarthritic. And clearing questions like what we call the red flag is the patient has a weight loss, night pain, history of serious pathology, systemic unwilling, fever, night swelling. This give you an caution that there is something which is more serious. So the investigation for the knee can be categorized into aspiration and the culture of the fluid, blood, X-ray for the joint, chest X-ray, MRI, manipulation under anesthesia, and arthroscopy examination. So when you examine for, this is the 4 categories for the examination: look, inspection, feel, palpation, measurement of the joint and around, and the movement. This is a test with either dynamic or static. So for inspection, expose both lower limb. It is very important, and not the joint itself. And look for the position. Look for from standing, sitting position, supine position, and the prone position. And this is the knee inspection. When you examine the knee and inspect it, looking for the wasting, looking for alignment, deformity, shortening, swelling, and don't forget that you examine the joint above and joint below, like you have the foot. And this is an example of an inspection. So sometimes the inspection not for the same style, but it can be affected other side like spine. For an inspection, look from anterior and posterior. Is it symmetrical or non-symmetrical, or symmetry, swelling, bruises, scarring, rashes, deformity, wasting, and the bruises. And if there is a dilated vein, it means that is it a heat. Patellar position, quadriceps extensor apparatus intact or not. And this is an example of semi-bronze bursa swelling from the popliteal area. Wasting is very important. Looking in the sides, the quadriceps wasting, and always looking for the vastus medialis wasting, very often seen after an old injury to the menisci. But it is not only swelling, wasting, it is sometimes there is swelling, and this is like hyperlipidemia or lymphedema, and this can be affecting the misdiagnosis. Also, when you expect looking for alignment from the genoverum, the bow legs, or genovalgum, can be predisposing to patellofemoral syndrome. And also for the center of the gravity, is the center of the gravity going from the greater trochanter to the center of the knee to the malleoli. But if it is the knee behind this, it means this is a recurvata. If the knee in the front, there is an flexion deformity of the knee. And this is in a correct and correct position related to the patella and the second web space. This means about the tibial torsion. Also look for the gait. It's very important when genoverum, varus, my pigs, and genovalgum, which is the common position in the female. This is an example of the patient with an flexion deformity of the knee, and also with tibia vara, and flexion. Both of them can be presented in one patient. And this, when you examine the knee, look for the patellar position, can be subluxated, like in the recurrent dislocation of the patella. And the inspection of the patellofemoral syndrome, it is very important to looking for the J sign. The J sign is a patient supine or sitting, and the knee extended from a flexed position, lateral deviation of the patella. And you will see this in this video. And also habitual dislocation of the patient can be habitually dislocated the knee and keeping in this position. And this is very important when you examine the patient. and also for looking for the patellar shape and the presence of a bipartite patella, which is presented as a manifestation as protruding prominence in the superlateral aspect of the knee. This is the example of the bipartite patella, and this is the swelling in the superlateral portion of the patella. And when you palpate it now, you have to palpate it starting from the joint line, and you have to know about the anatomical landmark. And this is very important to know where is the patella, where is the lateral condyle, the patellar tendon, the tuberosity, and the medial condyle. And looking for the swelling, where is the effusion, lateral, medial, prepatellar bursitis, and the bisancerous bursitis. And this is the bony landmark. It's very important to know and where to, you are going to palpate. So when you palpate it, divided the knee into 4 zones: the anterior zone, medial zone, lateral zone, and posterior zone. This will be facilitated for you to locate it, where is the pain and where is the manifestation and where to put your fingers. So when you palpate it, there is a superficial palpation, which is very important. Look for the temperature comparing to the other side. Look to the skin surface and the elasticity of the skin and check for the swelling and signs. This is what we call superficial palpation. Then go for the anterior part. Examine. You're starting by the quadriceps is very important. If there is a defect, is a swelling or abnormality. And then go for the bony prominent, like tuberosity, like Osgood-Schlatter disease. And then examine for the soft softening, like in prepatellar bursitis, superficial infrapatellar bursa, or deep infrapatellar bursa. And you can sometimes, from the anterior part, you can examine the bisancerous bursitis. This is how to palpate it, starting with the flexion from the lower pool, then the patellar tendon, then the tuberosity. And from this area, you can find 3 diseases. In the inferior pool of the patella, you find what we call the Syndrom-Johnson syndrome, which is an traction of bursitis about the lower pool of the patella. Patellar tendon sometimes can be what the patellar tendinosis or patellar rupture can be occur, or patellar insertion as a tuberosity was manifested by Osgood-Schlatter disease. This is an example of the 3 areas when you palpate it from the lower pool and tibial tuberosity and the patellar tendon. Also in the proximal tibia, it is very important traction of bursitis, which is an Osgood-Schlatter disease, and it can be manifested in children, teenagers. And the prepatellar bursitis, a house-made knee, an egg-like swelling in the anterior to the patella. It is very important, anterior to the patella, and an induced formation can be seen on palpated on the prepatellar bursa in the chronic inflammation. And don't forget the infrapatellar bursitis, الكلارجمان knee اللي هو الراجل في الصلاة من كتر الصلاة فبيقدر يحصل له manifestation على التبيروزيتي. So to differentiate between housemaid and between the clearing man knee, this is on the anterior part of the patella, and this is the anterior part of the tibial tuberosity. This is the clearing man's knee, or housemaid, and deep infrapatellar bursitis can be manifested in the anterior part of the knee. Then go for the medial part of the knee. There is 3 structures which is very important: the joint line, the medial joint line, the medial collateral ligament, and the bisancerous bursitis. So when you examine the knee for palpate the joint line in the anterior part, palpate the medial meniscus, anterior portion, and the coronal ligament, and then go a little bit in the midline, the rotation of the knee. So you make a movement of the menisci. When the tibial internal rotates, the medial meniscus is palpated. But when the tibial external rotates, the meniscus is repositioned, retracted. And this is very important to understand this, which this is representing the McMurray test. And then go a little bit in the midline. This is, you have palpated the medial collateral ligament, which is composed of 2 ligaments, the superficial part and the deep part, The deep part is composed of the tibiofemoral, femoral meniscus and the meniscotibial component. Then go a little bit medially behind. You will feel that the bis anterus muscle, which is the sartorius, gracilis, and semitendinosus muscle, and each one separated by a bursa in the anteromedial part of the knee. And then you can feeling that this is swelling the bursa, which is bis anterus bursitis. Then go for the third zone, which is the lateral, and you find that the joint line and the lateral collateral ligament, head of the fibula, and other structures. So in the chronic lateral meniscal tear, a localized band of the cerebellum may be occur along the lateral joint line, creating a characteristic bulge. This bulge means that there is a chronic lateral meniscal tear. Don't forget to differentiate it from the meniscal cyst, and this is the cystic-like conditions. This is an example of the lateral meniscal cyst. And then when you examine the joint line, you examine for the lateral meniscus and the coronal ligament, and then go a little bit in midway, which you feel that the lateral collateral ligament. Then make an leg 90-90, and you will feel that the lateral collateral ligament, it is accessible to palpated by this position. And then you examine the biceps tendon, and you will feel it and follow it until the head of the fibula. Then you examine the iliotibial tract. This is a simple test. Ask the patient to put the heel on the ground and ask him to push the backward on the ground. There will be contraction of the iliotibial band, and you can be palpated this. And then you go behind the head of the fibula and make telling signs for the common peroneal nerve. And then go to the fourth zone, the zone number 4, in the posterior aspect of the knee, and you examine any swelling or any abnormality in the posterior aspect of the knee, the Popliteal Fossa. And the Popliteal Fossa, you have to remember that it is have a medial border, upper lateral border, the medial is semimembranous and semitendinosus, lateral biceps femoris, and the common peroneal nerve, medial head of the gastrocnemius, and the lateral head of the gastrocnemius. This is triangular. If there is a swelling in it, it will be semimembranous bursitis, and has a characteristic very important. The patient, when extends the knee, it appear. When he flexes the knee, it will be disappear. So to differentiate it with other swelling. The popliteal cyst, the Bahaa cyst, also known as a popliteal cyst, is a benign swelling of the semimembranous, or more rarely some other synovial bursa. And this is an example how to inspect it and palpate the semimembranous or popliteal cyst. Then we'll go for other palpation from the anterior part, examine for the joint fluids like effusion. So you'll do milking, which is effusion. Effusion is assisted by milking the fluid distally from the suprapatellar pouch, pushing down, and the fluid will be collected under the patella. And this is then a pallotomen test. When you're pushing the fluids, the patella, it is raising by the fluid. You're pushing down, you feel that the patella, it is like floating. And this is an example how to examine. Palpated another, don't forget, after the traumatic, there is an effusion. So this is mean immediately, it means that it is a hemoarthrosis only if the structure in the joint is involved. So if the patient from the history has a swelling immediately post-trauma, this you have to think about hemarthrosis. And this can be from anterior cruciate or posterior cruciate ligament, ACL, BCL injury, or meniscal injury, or patellar dislocation, or intra-articular fracture, like tibial plateau fractures. And you have to differentiate it. Remember that the sole collateral ligament, medial collateral ligament, or lateral collateral ligament sprain when not causing any effusion. What about the effusion of non-traumatic effusion? Think about the osteoarthritic rheumatoid arthritis, gouty, metabolic disease, pseudogout, Reiter syndrome, and infection like gonorrhea and other like tumors. What about how to make a palpation for the test for the patellar mobility? Then when you examine, you have 3 tests. You can do it: patellar gliding, patellar tilting, and patellar grounding test. The positive result on these tests are considered with diagnosis of patellofemoral maltracking syndromes. This is a patellar glide that assesses the patellar mobility by moving the patellar displacement of more than 3/4 quantity, suggests patellar hypermobility causing by poor medial restraint predisposing for the patellar maltracking syndrome. And this is an example how to examine and moving the patella side to side. And this is how to divide the patella into into 4 quarters. And the patellar testing, the patellar ground test, can be done by positive way or active way. Positive way, the crunching sensation transmitting through the patella when you ask the patient, when you're moving the knee by yourself. Active by activity, asking the patient to do an flexion extension, you will feel this crunch sensation on the knee. What about patellar tilting? It is a positive test. The lateral aspect of the patella is fixed and it cannot be raised to the least horizontal position. Indicated tight lateral structure means that there is an iliotibial band predisposing to the patellofemoral maltracking syndrome. And this is an example of the patellar tilt. What about the patellar grinding test? This is the patient in the supine position with the knee extended. The examiner displaces the patellar inferior into the trochlear groove and asks, making a pressure on this, or asks the patient to make an active flexion of the quadriceps. He will feel a pain, which is a test for indicated the patellofemoral maltracking syndrome. This is a test how we can do it. Apprehension test, which is mean that like in the chondromalacia patella, the patient is apprehension if the examiner tries to move the patella laterally, positive after the patella, like in subluxation and in severe patellofemoral maltracking syndrome. What about the movement? The movement you examine as active and passive. It's very important to know the range of the movement. In extension, it is always 0 and maybe accepted hyperextension to 5 degrees. And the flexion is 135, but the different from person who are thin or big thigh. The range of motion, this is flexion 140, extension up to 0 or -10, internal rotation from 10 and external from 10 degrees. Always comparing the other healthy knee. It is very important when you examine one part, examine the other part, the other knee, healthy knee. The best way to assess the range of motion is in a prone position, not in the supine position. And this is the way to examine the range of the knee motions. This is a very important and it's a simple test to exclude if the patient has a flexion deformity or has an, if the patient can be squat This means that he has a full flexion. If it's not, you better check for how much is the flexion in supine. And how to examine for extension. Ask the patient to stand on the heel. If he can stand, this patient has a full extension. If cannot, this means that the patient has something in a limitation of extension, and you have to investigate it. This is the simple test. You can assess the function and the range of motion of the knee. What about the internal structure? This is the internal structure. We have the menisci and we have the ACL and the BCL. This is the McMurray test. Which one is the right? How to examine the knee? It is better to do when holding the heel or the holding in the distal end of the tibia. When you have a screwdriver, you have to hold it from the head, and it's very important. And this way, it is not a correct way to examine, to do an McMurray test. This is a right way to do an McMurray test, to hold the limb from the heel. And the menisci, we have many tests, McMurray test, Steinman test, and Apley test, and we'll go through it one by one. So the McMurray test holds the knee with one hand, placing your finger along the joint line and flexes the knee 80 to 90 degrees, and holds the foot by the sole with the other hand. And we'll see it in the demo now. I wanted to highlight that when you examine the meniscus, you examine three parts: the posterior horn, the medial substance of the menisci, and the anterior horn. McMurray test examines the posterior horn and the substance, and not examine the anterior part or anterior horn of the medial meniscus. To examine the posterior horn, this is when we make a full flexion and they make an internal external rotation. This to examine the posterior horn, the medial meniscus or lateral meniscus. And then when you extend the knee, you are examining the substance, the part of the menisci. And this is how to examine the knee. You hold the heel and flex the knee to 90 degrees. And then you make a rotational. This is to examine the posterior horn and the lateral horn, internal external rotation. And then you extend the knee with stress valgus strain, and then extend it if the patient has apprehension or click or abnormal sound. This means a positive McMurray test. This is how to examine the patient. This is a special test we mentioned now, and you see it in the demo about McMurray test. The between valgus strain, rotation the leg or the foot externally, extended the knee if it is a pop or something or apprehension for the patient. This means that it is a positive McMurray test. Provided a varus strain and rotated the leg internally, this is the test of the meniscus, or click felt, positive McMurray test for the lateral meniscus tear. What about Apley grinding test? This is a patient laying prone and flexed his or her knee to 90 degrees, placing your hand on the patient head heel and pushing down to compress the meniscal between the femur and the tibia while rotating internal and external rotation. Depending on the area of the pain, medial or lateral meniscus tear will be elicited. This is an example how to do an Apley grinding test. And this is demo. What about other tests? This is an static test. Okay, we can do what we call dynamic test. The children sign the squat test. This is a squatting test, and it can be positive. And eagle test, this is, we explain that when you put the leg external or internal. An internal rotation and a patient squat, this will be elicit the pain on the lateral meniscus. And this is when external rotate, there is the patient expresses some pain on the medial joint line. This means positive medial. Thesaurally test. This is depend on the position and rotation of the pelvis over the single standing heel or the feet. And if there is external rotation of the pelvis, he will elicit a pain on the lateral meniscus. And when he do an internal rotation of the pelvis with rotational of the leg, this will be expresses the pain on the medial joint line. This means a positive for the medial meniscus. What about the other structure, which is stabilizing structure, collateral ligament, medial and lateral collateral ligament, and how to examine this? To examine this, you examine the knee in two positions. In a full extension, this means that you examine the medial structure of the knee. When you flex the knee 30 degrees, you are examining the medial collateral ligament, isolated medial collateral ligament. So it is very important when you examine the patient, examine it in full extension and in 30 degrees flexion. So if there is a pain, mild pain, this means that there is a sprain. If the pain with laxity, this means moderate sprain. If no fixed end point, this is a complete rupture of the lateral collateral ligament ruptures. This is a demo for that, and this is how to examine a patient. If you can, if you have a big persons, you can look for how the direction of the strain of the knee. This is the lateral collateral ligament. This is how to make a pressure and stabilizing the knee, and then making a stress test for the collateral ligament. This is how to apply a valgus stress with the knee at 0 and 30 degrees, and always have these categories. Pain, it is mild sprain. Pain with laxity, it is a moderate sprain. If no fixed end point, this is a complete tear of the medial collateral ligament. And how look for the direction of the force. The force is going in varus, outward pushing. This is mean that you are examining the medial collateral ligament. This is you examine in full extension and in 30 degrees flexions. And how to examine the patient, you can stabilize the patient by putting the other leg outside the table, and then examine the patient to fix the patient and not coming with you. Special tests, you have now the ECL, which is the anterior drawer test. The patient supine with the knee flexed 90 degrees, stabilize the patient foot by sitting on it, the cup your hand around the patient knee and drawing the tibial tower. There is a specificity and sensitivity. This test is sensitivity about 43%, but the specificity is 87%. And this is the translation, how to translate it, the tibia over the distal end of the femur. And this is how to do the anterior test. This is another test, the Lachman test, which is very has a very sensitivity and high specificity. The patient supine with a knee flexed 30-degree pull on the tibial toward you, and this is a very important test. And this is when you have a patient and you have a small hand, or the examiner is a small hand and the patient with a big guy, you can do this by this way. This is some modification, and you will see it in this demo. One plane, huh? This some modification for that Lachman test. So this is how to do a Lachman test, and this is some modification. If you have a big guy, or you have a small hand and you cannot grasp the leg. Lachman test and the true drawer test are a positive if there is an increase in the amount of the anterior tibial translation comparing with the opposite leg, or there is no firm end point. This means that a complete rupture of the ACL. What about the pivot shaft test? Is a very specific test. This is highly specific for detection of the ACL injury. It is very important, and it is sometimes it is painful, and it is better to do it during anesthesia or pre-operative when you are putting the patient under sedation or with anesthesia. And this is how to do a pivot shaft. And we'll see the pivot shaft is an anterolateral instability. The lateral tibial plateau subluxated in extension, and it is reduced in flexion by the iliotibial trap. It can have a 3 grade. Grade 1, which is a glide into the place, is the tibia, and the grade 2 is a pop into the place of the tibia, and the grade 3 is doesn't reduce at all. This is the 3 grade of the pivot shaft, and this is a demo for how to do a pivot shaft. This is a special test for ACL, and each one has a specificity and sensitivity, but the most one, which is the Lachman test, giving about 85% and 90 sensitivity, and 94% specificity. There is a very important term. It is called unhappy triad. This is mean injury of the tree structure, and this is a severe injury. There will be medial collateral ligament, ACL injury with the medial meniscus, and this is called the unhappy triad. What about the PCL? Now we examine the ACL. Now we go for the PCL. It is a posterior drawer test. It is opposite to the anterior drawer test. I stay in the same position as for the anterior drawer test, and which is the tibial posterior. It is very important to differentiate it between PCL injury and sometimes with subluxation. This is very important, what we call the sag sign. And you can do it by this way. It is a very simple. Another way of testing PCL is a sag sign. You're holding the 90 degrees for the knee, with holding the heel. There will be sagging of the tibial tuberosity. And this is the position of the patient. And this is from the lateral side, comparing both knees, what we call the sag sign, the posterior sag test, good free test. And there is another modification. You can do it by this, the posterior drawer test by this way, or good gravity test. But the very important is the quadriceps active drawing test. The patient makes the patient in the flexion, and then asks the patient to contract the quadriceps. The quadriceps has an patellar tendon, and the patellar tendon has attachment to the tibial tuberosity. This will push the tibial tuberosity and the tibia anterior. This means that there is a positive posterior collateral ligament injuries. There is another test which can be done, like dial test, Veltri DM, and posterior lateral door test, where positive reverse pivot shift and external rotation recurvatum Hodgkin test. We will speak about the dial test because it is very important, because it represents the PCL with a posterolateral corner. The dial test it examines the patient in the prone position at 30 degree and at 90 degree. At 30 degree means that there is difference in the rotation of the legs. This means that this patient has a PCL injury. At the 30 degree and the 90 degrees, this patient has an PCL and PCL and BLC and BCL. Positive more than 10 degree asymmetry. 10 degree more than the normal leg at 30 and 90 degrees means that this is a positive test for dial test. What about the iliotibial band? The iliotibial band has attachment to the upper part in the hip and in the running to the side, to the knee, and a very important stabilizing structure in the lateral part of the knee. And this is an example how to do an upper test. Iliotibial band. This is the way, if you have a tight band, it will be stay in the abduction. What about relaxation related examination? When you have a knee, don't forget to examine the hip, the spine, and the ankle and the foot. It is not only the knee. Sometimes the patient has pes planus and has external tibial torsion and sometimes affecting the knee. Also, don't forget to examine the isometric muscle testing, and also don't forget to regional lymph node. Every patient in musculoskeletal, you have to examine the neurovascular. Never pass the patient without examination of neurovascular. So remember the 5 P's. Remember for the pain, pulse, pallor, paresthesia, and paralysis. This is a neurovascular examination. It is very important in the knee when you examine, or the lower limb, the peroneal nerve. Look for the, just ask the patient to make a dorsiflexion. This means the peroneal nerve intact. And if he can make a plantar flexion of the big toe, this is the intact of the tibial nerve. It is very important to examine the neurovascular. And still, some people who is going to exam to forget that to examine the neurovascular in the lower limb. What about the pain? Don't forget that sometimes the pain coming from elsewhere. It's coming from the hip. We have many patients who has an asclepic capital femoral epiphysis and complaining with the knee pain, and people examine the knee and forget to examine the hip. If a knee pain can be referred from the lumbar spine, like herniating disc, or from the hip and the ankle. The pathology, do not forget to do a gross hip and ankle examination. Test the motor strength, sensibility, and deep tendon reflex, and always examine both knees. Don't forget, this is a very important slide you have to remember. Sometimes when you are examining the patient, you can make a dynamic examination. This is the OSCE and how to examine the patient. The people, just I put 1 minute, how to present yourself to the patient. You have to introduce yourself. You prepare your hand, clean your hand, because the patient know well, and then you will go looking, feeling, and as we mentioned before. Sometimes you have to make the commentary. This is what we call the instrumentation measurement for examination of the knee. This is the Daniel and Larry Malcolm, 1994, to examine dynamically. And GNPR, this is a dynamic examination of the knee, and the robot measurement and the stress radiography. This is an example of the instrumentation measurement of the knee. At the end, don't forget, لما تمر على العيان كل يوم, you have to add it for you. Look for the more signs. يبقى يجب على كل واحد منا أن يسعى لتحسين مستواه أثناء المرور الدوري. مش ناخد المرور كده كحاجة روتينية، وأن يرى في كل مريض فرصة ليست فقط لخدمة البشرية ولكن لإضافة إلى المخزون المعرفة الطبية. في الآخر بشكركم وأعتذر على الإطالة، وأشكر بنها والجامعة بنها ممثلة في الأستاذ الدكتور محمد أشهب والجميع، وكل سنة وأنتم طيبين.
Thank you so much, sir. متشكرين جدا دكتور بهاء على ال very interesting and informative and illustrative talk. بصراحة يعني احنا كلنا استفدنا منها يا فندم. كل الاتنديز الله يخلي حضرتك يا فندم. كل الاتنديز send their best wishes to you, sir. One of the interesting in the attendees, one of our colleagues from Jakarta, Indonesia, is sending his best wishes to all the panel and the speakers, especially Dr. Bahaa Kornah. Best wishes to him and all our colleagues in Indonesia. Thank you so much, Dr. Bahaa. Thank you so much, sir.
الله يخليك يا دكتور محمد، ربنا يكرمك.
شكرا يا فندم على وقتك الثمين اللي حضرتك
قضيته. ربنا يكرمك. احنا لا دي رسالتنا ولازم تعزم، يعني احنا
صراحة محاضرة أكثر من ممتعة يا فندم.
الله يخليك، ربنا يكرمك. متشكرين.
أنا مش شايف questions قدامي. في اي questions to بروفيسور بهاء؟ هي المحاضره مش محتاجه questions، هي ما شاء الله very illustrative، فيعني انا مش شايف ان هي في حاجه to ask about يعني.
الله يخليك. انا هعمل سلايد شير، ستوب الشير.
شكرا يا فندم. اوكي يا فندم.
دكتور محمد.
ايوه.
السلام عليكم.
سلام الله وبركاته.
هو في سؤال بس يقول له اللي هو بتاع
اوكي اتفضل.
هو طبعا مش سؤال، هو بيقول ان هو انا ممكن استغل الفايل بتاع السيشن ديت، وهو ده من ايفان.
ده حد بيسأل يعني؟
كان في سؤال بس هو ما فيش حد تاني. هل في سؤال؟ Good evening, Professor. I get certification of attendance. يعني بيقول ان هو هل ممكن يريكورد الكلام ده ما فيش حاجه تانية.
هو اوريدي التوك هيبقى ريكوردد وهينزل على بعد اذن استاذنا على اليوتيوب شانل، فلو حضرتك اكسبتنج دكتور بهاء
طبعا ده حاجه جميله يعني.
ربنا. احنا في يوتيوب شانل خاصه باسم العظام يا فندم، في نهايه كل اسبوع بننزل كل السبيكرز اللي اتكلموا التوكس بتاعتهم في نهايه كل اسبوع، بحيث لو حد ما قدرش حضرتك يسمع التوك بتاع سعادتك يرجع على اليوتيوب شانل يشوفه يا فندم.
لا ده حاجه جميله، وانا يعني ببقى سعيد جدا طبعا في اي حاجه من الحاجات دي.
شكرا جزيلا.
بحط كتير قوي من محاضراتي موجوده حتى في السلايد شو، ان حب حد يشوفها ويتابعها.
شكرا يا فندم، متشكرين جدا يا دكتور بهاء.
شكرا يا
دكتور بهاء. شرفنا بحضرتك يا فندم، نورتنا يا فندم.